All right, so it is April 22nd, and it is Earth Day, so happy Earth Day to everyone. There was some great news about today that we're actually looking at cutting our country's emissions by 50% by 2030. I think it's a little bit lofty of a goal, but hey, anything we can change to save our environment for the kids that come after us is huge. So well, there are limits. Just say it. There are limits. So Bianca said, go vegetarian. There are limits to what I'm willing to do for the environment. Don't know that giving up meat is one of them yet, but probably my doctor would be happy for me to do that. I'm just saying. That'd be like telling me to give up coffee. That would be, rough considering I got a cop sitting beside me at all times. All right, so we're going to talk about extracorporeal shockwave therapy today. And so shockwave is a fairly new modality in the land of modalities itself. The process has been around for a while, but the actual use of shockwave in physical therapy is pretty young, and it's basically in its infancy at this point. So what is shockwave therapy, right? So shockwave therapy was initially introduced about 20 years ago for the use of kidney stones, urinary stones, salivary stones, all that type of stuff. So renal calculi, urinary calculi, stuff like that. Back when it started, I remember this because my dad had a kidney stone way back in the day when dinosaurs roamed the earth. And they put him in this giant bathtub full of, I don't know what type of water, I'm assuming saline or something, probably just regular water. And they turned on the machine, and the machine kind of hummed. And what it was doing is the whole time sending these waves through his body, the sound waves. And those sound waves then basically broke the kidney stones up a little bit. So it didn't destroy the kidney stones, obviously, right? But it made them easier to pass. And you guys talked a little bit about kidney stones with Dr. Johnson, and you got the referral pattern for them right out here. They can be really, really painful to patients, and especially if they're large kidney stones. You got to think of all those little tubes that's going down. Those kidney stones are basically like razor blades traveling down your urethra. So if we can break those up, we can. So we started off with that. And then we're like, what could this be used for, right? And this happens a lot in medicine, right? Especially in even pharmacology, right? As soon as we have one drug to treat something, we're looking at what else can we use it to treat. There's already, for example, the idea that we've come up with now with mRNA vaccines. There's already some ideas of, can mRNA vaccines possibly be used to develop a vaccine against HIV? Because the proteins themselves, between the spike proteins of COVID and the way that the HIV virus works, aren't all that different. So maybe, this whole process we went through with COVID will eventually develop a vaccine against HIV, which would be great. Same idea here. Shockwave was first for kidney stones and they're like, what else can we use it for? If it's used for calcification in the kidneys and the urinary system, right, in the bile duct, stuff like that, could we use it on calcifications of the actual body? And so they started coming up with the idea to treat it like chronic tendinopathies, lateral epicondylitis, plantar fasciitis. And so shockwave was born. The shockwave pulse itself is characterized by a high peak pressure, right? So the really, really, really a high amount of pressure delivered really, really fast. So 50 to 80 megapascals of pressure. That's a lot of pressure being delivered at once. There's a quick initial rise in pressure. I mean, when you guys learned about that ramp time for Russian, right? Where the ramp time is how long does it take for the Russian to fully kick in, right? Well, rise in pressure is the ramp time for the shockwave. And the ramp time is usually less than 10 nanoseconds, which means you can't even tell it. It gets there quick. There's a low tensile amplitude, meaning that the waveform itself is fairly low. The short life cycle, look at this. The life cycle of each pulse of high pressure is less than 10 microseconds. There's a broad frequency. If you look at that 16 to 20 hertz, right? and a velocity, meaning the speed that that shock wave propagates at about 350 to 1,000 meters per second, right? You figure that out for a second. That literally means that the shock wave, as it's being delivered, is traveling at about 1 kilometer per second. So, give or take half a mile a second. That's pretty darn quick. That leads to some really, really unique results in the human body when it's delivered. So this fancy slide here is great. I'm not expecting you to know this, and I'm pretty confident Dr. O'Neill's not expecting you to know this. This is more the scientific way it works. This talks about the rise in pressure and then what it does as that rarefaction occurs, right? Remember in physics, we talked about you have the compression where the waves are all compressed together, and then followed behind them, you have this open area where there is no compression, which is the rarefaction. That allows the tissue to rebound. Same idea happens here with shockwave, that the pressure is going to push in, but there's also going to be those rarefaction moments where the tissue rebounds as well from the pressure. So the high peak pressure of the shockwave is a result of a combination of both velocity and frequency of the shockwave. When I worked at a clinic that we had shockwave. I think there are 2 clinics that we have clinical rotations at that have shockwave, and I know that there are 2 chiropractic clinics in town that have shockwave. When I worked with patients with this, I would tell them it's kind of like ultrasound being delivered via jackhammer. And that would kind of scare them a little bit. And I did it kind of as an aside, kind of getting them a joke, right? But it really is true. There is going to be a piezoelectric effect coming from the shock wave, as well as a pressure effect happening. So it's going to drive the shock waves a lot faster. So it does have a little bit of depth of penetration, a little bit more than your typical ultrasound and stuff like that. The high velocities of waves when passed through a medium generate was essentially a controlled explosion due to the pressure differential. So as that wave hits in and that rarefaction collapses, there is a little bit of a controlled explosion that causes that cavitation effect. The energy is then dissipated and reflected at the tissue according to mechanical properties of the tissue that it passed. The pressure disturbance is propagated 3-dimensionally. So the nice part about this is where ultrasound kind of, because of the way the ultrasound waves kind of go out, as they go out, they kind of disperse across the tissue. Because of the way this is sent, it propagates deeper and actually travels to all the tissue in the local area. It also raises relative pressure of the cells around it, so you can get that cavitation and contraction going along with the compression and rarefaction. This will stress the cells, and in the case of something like a calcification, like if we had a calcification of a tendon or we had lateral epicondylitis, this can actually break up that unwanted tissue that's causing the problem. The stresses themselves are in the direction of the wave propagation, right? But there is impedance and dampening at the tissue boundaries, right? So if I'm doing lateral epicondylitis, I'm going to talk more about this when we get into the treatment style, but if I'm treating my lateral epicondyle, when I send those waves in, just like with ultrasound, there's bone down there. So although the sound waves and everything are going to go straight in, that bone is still going to cause a reflection, and it will reflect within the tissue. And then that tissue is going to reflect it back, and you get this steeping and attenuation of the wave where the wave kind of forms in this whole area that you're treating, causing drastic cavitation, right? We learned that there's good cavitation and then there's bad cavitation, right? You guys learned a little bit about that with ultrasound. If you want to remember back to when you talked about that a few weeks ago, right? The cavitation in the ultrasound is what we get to cause those tissues to vibrate, to release fluid in the area, to cause more blood flow to come to the area, cause it to heal. The bubbles yield water jets, just like with ultrasound, and that causes cellular tissue damage to the area that we want to remove. In the case of something like plantar fasciitis, where you have a really, really build-up calcification on that plantar fascia, it can break that stuff up small enough that it can be reabsorbed by the tissue around it and then sent out as waste. So this is kind of what one of the Shockwave machines look like. I didn't use this particular one here. The one that I used kind of looked like a gun. So it looked like this. There's a trigger here. It literally looked like a gun. And then the actual pressure head, which is what this is here, was out here, and that basically jackhammered in and out to deliver the pressure. This is a little bit fancier of a device because it looks like you don't even have to hold it. But just like with ultrasound, because there is a piezoelectric effect, meaning that there's a crystal that's going to send sound waves into the tissue, we're going to need a conductive medium, right? And with ultrasound, we use ultrasound gel. With shockwave, we're going to use the same thing. We can also do shockwave underwater if the device is rated for it, just like you could do ultrasound underwater and use the water as the medium. But you don't want to do ultrasound or shockwave without that conductive medium. Do you guys remember why you don't want to do it without the conductive medium? What happens?
Messes up the ultrasound head.
Yeah, right. Good, right? So if we were to put ultrasound on and we're just doing it dry, the sound waves are going to go down because there's nothing to cross that barrier of air between our skin and that ultrasound head. The sound waves are going to bounce back up into the ultrasound head and break that crystal. And the last thing you ever want to do is break an ultrasound head. They are not cheap. You can't do ionto, but you could do phonophoresis. And we're actually going to talk about that because, remember ionto, e-stim, phono, sound, ultrasound, right? And I've actually used that with some of them when I've had patients that can't tolerate, because this is kind of, we talked a little bit about with Russian, that Russian's a little bit intense. This is an intense treatment. And sometimes that can get the patients to kind of climb up the walls as it's going. So the amount of attenuation and steepening that occurs across tissue bounds accounts for most of the loss of energy. So there's going to be spreading of that energy across the whole tissue area, just like ultrasound, right? The more that we can provide direct contact to the skin with as nice medium as we can get to provide that nice transmission of the sound and the shock waves, the better that we're going to cause that energy to cross the boundary and enter the body. If you kind of hold your ultrasound head and just kind of float it in the gel, it doesn't deliver as an effective ultrasound to the body, right? That's why you taught when you have the ultrasound head, you put it down into the tissue and you kind of do a little bit of soft tissue with it. Same idea here with this. When we're delivering the shockwave therapy, we've actually got to get that shockwave head in contact with the skin as much as possible and make sure we maintain that contact at all times in order to make sure that we don't lose the energy dispersing into the air. So how does the shockwave generate? Well, there's an electrohydraulic effect, there's an electromagnetic effect, and there's a piezoelectric effect, right? So the electrohydraulic, that's the actual piston head going in and out as it's delivering, right? That's that electrohydraulic effect. Electromagnetic is because it's going to deliver a small amount of electric charge when it's doing that. Not enough that you feel it. It's not like e-stim. And then piezoelectric, because there is a piezoelectric crystal inside the head that is delivering sound waves along with the physical mechanical waves. When you get hit with all three of those waves, it delivers a large amount of energy in a short amount of time that can help penetrate into those tissue depths. How far does ultrasound penetrate? Do you remember? Is anyone willing to go on a limb here?
Or like 1.
Okay, 3.3 is the megahertz. Good, okay.
Yeah.
Right, so you have 1 and 3 megahertz, right? And which is the deeper penetration?
1.
1 is the deeper, good, right? And about how deep? How deep does most of your modalities penetrate?
I thought it was like 0.5 or something.
Well, it can be anywhere from 3 to 5 centimeters. Yeah, so 2 to 5, 3 to 5, somewhere in that range. And it just depends. Like hot packs, maybe not going to penetrate as deeper on me as it might be on some of you that are a little skinnier than me, right? So it just depends a little bit about what your body's made up of. The more water that's in the way, the harder that there is for penetration, right? You guys should have learned that with ultrasound. If you have a lot of adipose, which is high density of water, the ultrasound doesn't work as well. Same idea here. There's a lot of adipose in the way. It can impede the actual delivery of the shock wave. So the focal volume is what's the actual deliverance of the actual shock wave. The The focal volume is going to be manipulated to ensure the target tissue is treated, meaning we're going to use the appropriate head size for shockwave, just like we'd use the appropriate head size for ultrasound, right? For a smaller area, we need a smaller head. For a larger area, we might need a larger head. But just like with ultrasound, the bigger that head becomes, you get a higher BNR, beam non-uniformity ratio, right? Meaning that it's not as focused the bigger the head gets. It kind of spreads a little bit further as the head gets larger. Same idea with shockwave. The pressure field that we're going to deliver is measured in megapascals as a function of time. The main thing you're going to note in your notes if you are doing shockwave, because this is a lot of stuff, you're going to document how many shocks, we're going to talk about that in a second, how many shocks are delivered to the patient, and then what energy intensity delivered, which is in this megajoules per millimeter squared. So again, you're going to say something like 3,000 shocks at 50. And again, if your clinic has this, it'll make a lot more sense. To plantar fascia, right plantar fascia. Right? That's kind of what you would see in a note for this. Why would you have this? What this does, if you see this, I know now that I'm going to set my machine up for 3,000 shocks. I know what the energy or intensity I'm going to set my machine up at, and I know where I'm delivering it to. I'm delivering it to the plantar fascia. That's the whole point of your SOAP notes. The whole point of your SOAP note is so that somebody else can follow you and duplicate exactly what you did. So you need to be very clear and very specific on your notes, even with this, on what you're doing to the patient. The total acoustic energy will be calculated by the machine. You don't necessarily have to document that. But just like ultrasound, there is a diminishing return on it, meaning the more treatments they get of this specific treatment modality, the less it's going to start affecting them. Does anyone remember how many treatments about where ultrasound starts becoming less effective? I know it was in your textbook. To show who read the textbook. No one has an idea? It's about 12 treatments. At about 12 treatments, ultrasound starts becoming a little bit less effective. Oh, now I see how you're doing, John. Yes, you have a textbook, and it's a great text. Actually, Dr. O'Neill and I fought for this textbook. I'm just saying. We like this textbook better. The most important physical parameters when treating biological tissues in this is, again, those pulses or the shocks that you're delivering, and then the energy or intensity you're delivering it at. So what happens? Biological effects. What does this ultrasound plus hydraulic jack deliver to the area? It's going to cause tensile and shear stresses, right? What does shear mean?
Like very light?
You say very light, is that what you said?
Yeah, that's all I can think of.
Okay. Shear is when you take and you rub something on the other and you get a force that pulls. Friction. Yeah, friction is a shear, right? So tensile, right? The ability to hold stuff together. And then shearing is kind of that pulling and rubbing. So this is going to cause that at the cellular level. And again, a lot of times when I'm dealing with patients, even with ultrasound, they're going to say at the end of ultrasound, man, I really didn't feel much from that ultrasound. And I'm going to give you a little key phrase I like to use at that point when they're like, I didn't feel much from the ultrasound. Tell them, I understand you didn't really feel much from it, but you have to understand that ultrasound is working at the cellular level. This is working at the cellular level. Meaning when you get down to that micro level of treatment, it may take a little bit for the body to recover and actually start feeling a result from it. Laser is very similar. It may take a little bit for you to feel an effect from a laser. Same thing here. Now, with this, because there is a little bit of meat tenderizing going on, they definitely feel that part of it. But the actual tensile force and the shear stresses may take a little bit. And those bubbles occur again, which is similar to ultrasound, that cavitation, which causes stuff to flow into the area. The bubbles will then collapse the pressure of the wave. So we're going to cause bubbles to form in the area, and the water and the tissue in the area. Those bubbles will collapse, creating energy jets that'll push and pull the tissue in the area. Just like ultrasound, there is an indirect effect. There will be some heating that occurs. Right now, we know that with continuous ultrasound, we get a pretty significant amount of heating. With this type of extracorporeal shockwave therapy, the ultrasound operates on a pulsed frequency. So that means it's not always on. It's going to go on and off, on and off, on and off, which makes sense because that head is going in and out at the same time. And if it was constantly on, you're going to end up with some periods where that ultrasound's on and the head's not in contact with the body. So it needs to go on and off slightly, right? The heating effect from shockwave is not going to necessarily be from the ultrasound. It's going to be from literally, right? If I sit here and pound my hand over and over again, and then I was to look at my hand, my hand's red. It's increased the local tissue there because of, I created a little bit of cavitation in the area and created those water jets, even just with this. So depending upon the water content of the tissue and the time between shockwave applications will depend upon the actual overall effects. Again, somebody that's more adipose may not get as much out of this as somebody that we can actually get directly down to the muscle or the tendon we're treating. Most clinics, when we deliver shockwave therapy, will only do it once per week. Number one, it's uncomfortable. And number two, we've got to allow the tissue to heal from that, right? Have any of you seen somebody do like Graston or instrument-assisted soft tissue mobilization, where you use the blades and start scraping? They're similar, right? They do it about once a week. They're not going to do it necessarily every treatment, because if you do it every treatment, expensive butter knives. They're exactly right. Again, look, we saw a butter knife. We said, hey, can we use that in therapy, right? But if we took that Graston technique and did it every single, say the patient was coming 3 days a week, and we constantly did it to that area because we're kicking up the inflammation, if we just keep doing it, we're going to cause a chronic inflammation effect there. We need to allow it to heal down and rest, right? That's why even with the gym, right, there are some things where you have to let your muscles heal after working them. You can't do arm day every single day going to the gym. You've kicked up inflammation. You've got to allow your inflammation to kind of tone down a little bit so that your body has a chance to heal. On bone, we can use this. Now, this is where I'm going to warn you. Just like ultrasound, would you want to do a treatment that is delivering a physical punch along with sound waves to a fractured bone? No, right? Think about that. And here's the, sometimes I've encountered this in the clinic where I'm doing ultrasound on somebody's ankle and all of a sudden they scream at me because all of a sudden it hurts really bad. Because guess what I just found? I found out they had a fracture in their ankle and we didn't know it. Because what that cavitation does is causes that fracture to do this, right? We definitely don't want to do even extracorporeal shockwave therapy, shockwave, over a fractured bone. So the bone's got to be intact, right? But what if I have a calcification on my bone? Sure, that's what this is intended for, is to break up that calcification, right? You guys have heard of lateral epicondylitis and medial epicondylitis, where those tissues kind of harden down and get stuck. That's a great use for this. The effect on the bone primarily occurs at the interface between cortical and cancellous bone. Do you remember what cortical and cancellous bone means? What's the easy meaning of that?
The inside and outside of the bone?
Yeah, good. The inside and outside, or the soft and the hard bone, right? Yeah. So when we send the shockwave into it, when it affects bone, it affects at that interface between the two, right? That's down at the endosteum, right? The inside of the bone. The acoustic streaming causes cavitation, increases cell permeability, allowing increased vascularity and bony regeneration. Meaning once we've got, now I said not on a new fracture, on a healed fracture where we're starting to get a callus. Sure, we can use this on that. We could, absolutely. So Stephanie asked, could you use tuning fork to rule out a fracture? Absolutely. And there are some times where I'm pretty particular about this, usually ankles, because I've had bad luck with ankles before, because the ankle is kind of a whole jumble of tissue down there, and the doctor will take a quick x-ray and say, oh, there's no fractures. And then I'm like doing, you know, mobility on it, and the patient's suddenly screaming in pain because we found a fracture. So yeah, I could actually take a tuning fork, tap it on the bone. If they scream at me and punch me, then they probably got a fracture. Could also do this and then really get punched. They're going to take the shockwave and just put it right on my forehead. When the shockwave goes down, it's going to cause the localized area, just like with ultrasound, right? So when ultrasound sends those waves down, let me get my little drawer up here, right? So do I have a pink color? I have a pink color. That's close enough. So there's my skin, right?
Yeah.
Hey, can you hear me?
Yeah, I can hear you.
What up?
Nothing's up. So here's our ultrasound head, right? When ultrasound sends those waves down in, it's causing cavitation, that microstreaming effect of those bubbles to go up and down. When those bubbles go up and down, what happens is the body says something's going on in this area, inflammation is kicking up. In order to rectify the inflammation, we've got to send more blood to that area. When more blood comes to that area, it also brings along nutrients, all your macrophages to clean up the gunk that might be in that area, right? All the eaters of the dead, and some of those T cells to clean up that area. Same idea here with shockwave, right? Shockwave is going to cause these pulses to increase the inflammation briefly in that area to allow for more blood flow to come in, bringing more healthy stuff to come in, which will ultimately lend to healing. With shockwave, with bones, the main thing with that is we know that if we're going to go over like a hard callus or something like that, we want to keep it to under 2,000 pulses. This is, if there's one thing on your boards you might get a question on, this might be one of those. That if you're treating a healed fracture with shockwave, you need to maintain less than 2,000 pulses to stimulate healing. Can you do more? Sure, but that's going to be on a PT, not on us. The idea is more than 2,000 pulses can kind of start working negatively on that and break up some of that callus, and we don't want to do that. On tendons, same idea happens here, right? The biological effect shockwaves on tendons are the same as bone. The direct mechanical stress causes tensile and shear forces, so it causes that tendon to kind of vibrate back and forth. Now let's think about it. If I've got a tendon here, and here's my lateral epicondyle, and I get the tendon attached, and I'm stuck down to that. If I start causing that vibration to happen, right, my tendon's going to start vibrating, and eventually I'm going to pop off the bone that I'm stuck onto. Not enough force to rip it off and cause an avulsion fracture, but enough to break up that gunk, typically calcification, that's binding that tendon down. And so most of the effect when we're doing tendons is going to occur at the junction between the tendon and the bone. Further down, right? So like down here in the palm, where most of our muscles are tendons, right? All your muscles for moving your fingers are up here in your forearm, right? Down here, shockwave may not have as great of an effect because there's not direct bony attachments down there. And not only that, but I don't think I've ever done shockwave on a palm. That would be kind of scary. There are some clinicians, specifically orthopedics, so DOs and stuff like that, will use shockwave to help with non-union fractures. This is not something we're going to do in physical therapy. So they will actually use a shockwave to force a non-union, so a fracture that might be sitting like this, to force the fracture back into union. What's a pseudoarthrosis? That looks weird.
Does that mean like stratified?
Okay. You're on stratified tissue is what causes it. Yep.
Okay.
You're on the right thought process. So I know that you're on
Right.
patho and you had this.
Is it
Go ahead.
fake arthrosis?
What's that?
Fake arthrosis?
Yeah, fake. It's a fake joint, basically, right? So if my bone kind of gets laid down, and again, I get something like this, I might get a joint that's not supposed to be there. So I've got to get that union to go back. So I've got to break up that new joint that's happened and then reunionize the fracture. Acute fractures of the tibia. I don't know why they would do that, but I'm going to leave that up to the doctors. I'm just looking at that going, that just doesn't even sound like a good idea, because I know what the pain of getting the shockwave is like. I can't imagine that. Femoral head necrosis. I did have a DO in town that uses this for this. And what he uses, so femoral head necrosis, what does that mean is happening at the femoral head?
It's dying. The bone is.
Tissue is dying.
Yeah, the bone's dying, right? So bone death, exactly, right? So let's think about that for a second. I'm trying to mute my thing so it doesn't make any more noises. There we go. If we have femoral necrosis and we use some of that shockwave, right? What's going to happen is we're going to send in more blood supply to that area. And the blood supply is dead already. So we increase the localized blood flow, which means we'll bring in more of the stuff that's going to eat kind of away at that dead tissue. And the theory behind it from the DO standpoint and the orthopedic standpoint is, if we can get rid of some of that dead tissue by bringing in some white blood cells to clean it up, that femoral head might last a little bit longer before we have to replace it. But make no bones about this. If you have femoral head necrosis, you're going to have to get that femoral head replaced, right? They're going to have to do a hip replacement. But if they can stave it off for a little bit and maybe let you function for a little while before getting the total hip replacement, it does help. Because you guys have to understand, how many of you guys have seen somebody with a total knee or a total hip? Is anyone in here? I'm assuming most of you have at some point.
No.
Yeah, right? Does anyone know about what the life cycle is on those? How long do you might need a revision? Does anyone have a guess? Okay, 10 years is a safe guess. Yeah, it used to be about 8 to 10 years. That's it's a little bit longer now because, and we're going to learn next semester about that. We used to use ceramic parts. So now it's about 12 to 15. Yeah, so Bianca's about right? So it's about 12 to 15 now. Because we're not using, think about that for a second. We used to use ceramic parts to replace the joints. That doesn't sound like a smart idea to me, but it was what we did. Because ceramic is, doesn't cause, there's no problems with the body, doesn't react with the body, stuff like that. It's non-reactive. But it's just like anything else that's ceramic. Ceramic fractures and breaks, right? So now we use, sounds fragile, exactly. That's why it was 8 to 10 years before, right? Now we use titanium, right? And so when we do things like a total hip revision or something like that, we can use this acoustic shockwave to help break up any of that tissue that binds down. You guys are going to find really quick when you first start treating patients that have total knees or total hips, the problem isn't necessarily the total knee or the total hip. The problem is the scar tissue that builds up around it. Right? If I get a total knee and I've got, scar tissue running down the underside of my patellar tendon, it binds and sticks everything down and I lose motion. We can use this to help kind of break up some of that nasty buildup. This is primarily what I use most of my shockwave for, was epicondylitis and plantar fasciitis. Plantar fasciitis, I had phenomenal results with this in the clinic that I worked in, even though I hate feet. It has been approved by the FDA, meaning we can do shockwave. So there's only limited treatments that as PTAs and PTs, we can use shockwave right now. Plantar fasciitis is one of them. Condylitis are another, and then also for trigger point release. But what I found is when we get that plantar fasciitis, so this is the plantar surface of my foot, right? This is the palmar surface of my hand. It's also the plantar surface of my foot. When those tissues bind up and get stuck down, they stick down to all those tiny bones underneath, right? And you get buildup and gunk all in that plantar fascia. And if any of you have had plantar fasciitis, you know it hurts. It is not a comfortable feeling. Here in town, you know, the clinic I worked pretty heavily with culinary. We would see a lot of the servers in the casinos coming in with plantar fasciitis. Well, why was that? Because they were forced to wear shoes that weren't exactly ergonomic walking around the casinos, right? I'll never forget, we had one that was at, I think, the Gold Coast, who came in and she's like, yeah, we're supposed to wear these 7-inch heels. I'm like, that puts your foot like this. Yeah, your plantar fascia is going to get all bound up from it, right? So we can use this to go in and break up that binding down tissue, the itis, the inflammation, and it really treats the plantar fascia. And we're going to talk about at the end here why modalities aren't everything. Because I had one patient that I remember very in particular, and I'm pretty sure she's still going for therapy. We'd get her plantar fasciitis under control. She loved the shockwave, was uncomfortable. She loved the shockwave though. It would get her ready and raring in about probably 8 treatments. And then she'd be gone for 3 months. And then 3 months later, she'd be back. I got plantar fasciitis again. Well, why is that? Well, the modality doesn't fix the problem, right? Just like traction doesn't fix the problem. We have to do other stuff to help it. There are plenty of randomized control trials out about plantar fasciitis that show tremendous improvement for plantar fasciitis. Epicondylitis, remember we have lateral and medial epicondylitis that occurs, golfers and tennis elbow. This has been shown, again, to be able to be treated by the FDA for this. The outcome measures report significant improvements, specifically with lateral epicondylitis. I didn't have as much effect when I treated medial with this, but definitely lateral epicondylitis. I had some really good results with this because it helped break up some of that bound down tissue again. Out of your rehab book, I pulled a couple of things. So this Romp and Maffuley, looked at a quality case-by-case study that showed that a great amount of effect happened with patients that used shockwave therapy for tennis elbow under well-defined restrictive conditions. If you look at this, this is an amalgamation study. They looked at 10 different randomized control trials that included 948 recipients or participants. That's a pretty big group of people. And the result in pain reduction, when you look at the study, was from the control group that didn't receive shockwave to the after group that did receive shockwave. The after group recovered about 2 weeks earlier than the control group, and also had significant reductions in pain, subjectively reported pain, by about 2 to 3 points, which is pretty significant. This is the fun part about research. I like reading it. I don't like doing it. This is a new one that they're pushing right now for physical therapy to treat, which is calcified tendonitis of the shoulder. I know some clinics that do use shockwave to treat this, but understand that right now, the FDA has not approved shockwave for treatment of calcified tendonitis, which means if the clinic were to bill for this, that would be what?
Unethical.
Unethical and be fraud, right? Now, does that mean I can't do this? That's where you get into the gray area. I wouldn't want to do it because it's not approved by the FDA, because I don't want the FDA coming down on me. If the PTA does it, that's on them, or the PT does it, that's on them. But in Europe and Canada, this is used pretty effectively, especially with calcified tendonitis of like the supraspinatus, especially in the supraspinatus tendon area, right, and biceps tendon. Trigger points. This is another one I use this for, specifically trigger points of the piriformis. Where's piriformis at?
Lower back, inner abdomen.
Okay. Yeah, it's in the butt, right? So if you come back and you find that PSIS and you come down, you come into that meaty portion of your buttocks, right in that area is where your piriformis is, right? Piriformis is named for its shape, right? It's kind of pyramid shaped. What goes under the piriformis? Does anyone know? Yeah, the sciatic nerve. Good, right? So now let's think about it. I get a trigger point or I get a bind down point of my piriformis where it gets stuck to the tissue underneath it. It can actually get stuck to the sciatic nerve. And now every time you rotate your hip laterally or move your hip laterally, the sciatic nerve's getting pulled a little bit. Ouchie. Right? That can sometimes we look at sciatica and we think it's a low back problem. In reality, sciatica is a piriformis problem, which is why a lot of times when we treat low back patients, we're going to have them stretching out that piriformis with that nice figure 4 stretch, which we will learn next semester. But trigger points, it has been approved by the FDA for use on this. The only thing I'll say about this one, with plantar fasciitis, it's uncomfortable. With lateral epicondylitis, medial epicondylitis, it's uncomfortable. With trigger point release, Shockwave hurts. Because Shockwave is literally going to repetitively punch the area where that trigger point is, right? And you can go up, like I know I have a trigger point every day right here in my upper trap. Yeah. Just pushing on that, right? First of all, that's the way we're going to treat it. But just pushing on it already, I can feel kind of the whole muscle starting to tighten up from it. And that's just putting a finger into it. Now just imagine somebody coming going boom, 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 2,000 shocks in about 30 seconds. It does tend to kick that trigger point up initially in pain. But wouldn't that work on a very specific pain control theory?
Gait control.
Not gait.
Opiate.
Opiate, right? Because I'm causing pain. If I cause enough pain in that area, right? So if I just beat on that area enough, boom, 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 and now I go press, that doesn't hurt as much because now the whole trap's kind of sore, right?
So Mr. McKeever, I actually have a question about this. So like when we're doing opiate control, like of pain, do we release chemicals? Is that what makes the pain go away?
Yeah. So inside your body, you have endorphins, right? We know about endorphins, right? We learned about that from Legally Blonde. With endorphins, there's a very specific type of endorphin that is an endogenous, meaning inside of us, opiate. And what do opioids do? How do opiates relieve, and this is a little bit for next semester as well, but how do opiates relieve pain? What do they actually do?
Block, mask.
Yeah, they mask the pain. They block the signal, right? Same idea. So when we have that gait control theory, right, the rubbing of the head, we're closing the gate because we're starting to send that rubbing sensation instead of the pain sensation. Well, with the endogenous opiate effect, we create the endogenous opioids in our body to go to that area and mask off the pain. They basically go in and kind of shut down some of those pain receptors. And if you look at some of the theory and the high-level stuff on that, it talks about the endogenous opioids interacting with substance P. Do you guys remember substance P? Have you learned about that? I hope you learned about substance P.
I'm not sure that we did unless someone remembers it.
It doesn't sound familiar.
Okay. Substance P is an important thing to understand. Good. I love teaching you guys new things. So, what do you think substance P stands for?
Potassium.
Nope. Pain. It's substance P. We still don't completely understand this. Substance P is a specific nociceptive neurotransmitter. So a pain neurotransmitter. It causes your nociceptors to kick up. And that's what causes you pain, right? Again, I'm in here boxing somebody and somebody slugs me right in the face. Instantly, I'm going to get a shock of pain. Well, if I'm still fighting the guy, my body might say, yes, that hurt. But right now, the more important part is the guy's going to hit you again. Ignore that pain. So we can override substance P. And so a lot of the studies right now are looking into, is there a way that we can maybe cause substance P to tone down in the body? So substance P is this neurotransmitter we don't quite understand completely yet, but we know that it's integrated and integral into pain. So when it's up, pain levels are up. I was looking at a study from about 3 years ago, I want to say it was, at Berkeley, where they did a study of patients that have fibromyalgia. And they were able to detect higher levels of substance P in their cerebrospinal fluid, which would make sense, right? When you have fibromyalgia, you kind of hurt where? All over. And so, you know, a lot of the, and this is the race that pharmaceutical companies have right now, is to be 100% honest, is the first pharmaceutical company that can come up with a effective block of substance P is going to make a lot of money, especially if it's non-addictive, right? If we can come up with something that basically shuts off substance P, that's a good thing and a bad thing, because there are people that are born without substance P. Have you ever seen any videos of those people, the people that feel absolutely no pain?
I've seen like commercial like adaptations of it.
Yeah, there's a great video on a guy that's in California that feels no pain, and his whole right arm is covered in burns because he's burned himself so many times and not known it because he doesn't feel the pain. It's like, you know, I'll reach in the oven and not think about it and grab a hot pan and just pull it straight out. You know, because we open that oven up and we get closer. Oh, yeah, hot pad. Grab the hot pad. Or hopefully we think about it beforehand, right? So substance P is this neurotransmitter in our body that helps regulate our pain. The more substance P, the greater the pain levels. So then that takes me a step further away from Shockwave than I want to, but so then could it be that people that have higher pain levels maybe are more sensitive to substance P? Do you think that's possible? And this is just theory, not. Do you think that's possible? That maybe people that experience pain greater could just be more sensitive to it? Yeah, possibly. Right? Right, yeah. I mean, and again, pain we don't fully understand because, and we're going to learn this in 5th semester when we talk about pain neuroscience, which is probably by far out of all my lectures I teach, the PNE, Pain Neuroscience Education lecture, is my favorite lecture of all time. Because it teaches you one important fact. Even if I break my arm, I have no pain in my arm. There's no pain here. Where's my pain at?
Like your head?
Yeah, in my head. It's in my brain. To me, that type of thought process just, to this day, blows my, when I learned that way back when dinosaurs were on the earth, when I learned that, I remember arguing with my teacher about that. I'm like, no, if I stub my toe, it's my toe that hurts. And she's like, no, because the signal's got to get up to your brain, and your brain's got to tell you it hurts. If you stub your toe and cut your foot off, does your toe still hurt? Well, no. Right. So the pain's never been in your toe. Pain's in your brain. Interesting. So substance P, again, is that thing that kind of relates back to that. So when I have a localized area of pain, like a trigger point or something like that, that area is going to have a higher localized effect of substance P. And so opiates kind of block that substance. They block a little bit about that. That's endogenous. And endogenous, you don't get high from particularly. Now, you can get the runner's high, right? A few of you mentioned that you felt that runner's high before. It takes a lot sometimes to feel that. Or that high in the gym where you feel really awesome after working out really hard and you're just like, this was awesome. And then 2 hours later, you're sitting on the couch like, I'm hurting, right? Because now that high is gone. Same idea for getting high with drugs, right? That's the withdrawal effect that comes after it. So the endogenous opioid, we don't have necessarily a withdrawal effect from. We also don't have an addictive effect. Maybe. There's studies on that too, but that's beside the point. Does that make sense though for substance P? Sorry, I went off on a tangent there, but that's kind of an important thing to understand, especially for next semester. Because we're going to talk about substance P and Therax. So where do people experience a lot of their trigger points? I already said the butt.
Like
Where
in
else?
between your thumb,
What'd you say?
in between your thumb and pointer finger.
Okay, good, right? Good, trigger point there.
I'd probably suggest like knees, low back, shoulders.
Yeah, pretty much you can get it back in the, I've seen trigger points in the quad and I've seen trigger points in the hamstrings. And then you can pretty much say back/all, right? Back and neck, you can get trigger points pretty much the whole way up the back. And I guarantee you when we do that, the trigger point release class, we're going to be digging around in your low back and go, oh, there's one. Oh, there's one. You won't even know that you had them until somebody pushes on it. You're like, oh, yeah, that does not feel good. You can even get them in infraspinatus and subscap. Yeah, from behind the scapula, yep. Plantar fasciitis, you can get them in the feet as well, yeah. Not as much because there's not as much muscle down there, but what I found is patients that get trigger points in their feet, it's hard to determine if it's a trigger point or if it's more plantar fasciitis. Because trigger point would be in those tiny muscles in the foot, whereas plantar fasciitis would be more of the tendons. Yeah, I like the manual therapy class. Did you guys do your massage class already? Or is that coming up?
It's coming up. We haven't done it yet.
Okay, I'm gonna have to see when that is so I can come in for it. Because that's one of my specialties, so.
I think that's next Thursday.
All right, I will. I've got the recording, so I'll remember it. So what happens when we treat a patient? So this is the actual treatment technique, right? So first of all, we have to figure out trigger points. They yes and no, Anthony. So Anthony asks, is a trigger point the same as a muscle knot? Yes and no. Trigger points can be associated with muscle knots, but muscle knots typically are usually buildup of lactic acid, where the muscle kind of sticks together. Trigger points a lot of times occur at the neuromuscular junction, which is where the nerve dives into the muscle. So it's more of a neural pain versus a musculoskeletal pain, if that makes sense. So when we find trigger points, let's say I'm going to treat somebody's sole of the foot with trigger point or with trigger point. Got stuck on that with Shockwave. The first thing I have to do is figure out where their pain is. So the only way I'm going to do that is by palpating. So I'm going to go along the foot and I'm going to go, okay, do you feel it there? Do you feel it there? Ow, okay, there's one. And most of the companies that make the Shockwave machines will tell you, get a skin marker and put a dot or an X where you found pain. So a lot of times by the time I'm done with somebody's plantar surface of their foot, it looks like somebody just drew tic-tac-toe all over their foot because I've got X's everywhere. What that does is that gives me a visual area to treat because I can't remember where all the trigger points and knots and messes are on their foot. So then they're going to get about 1,000 to 4,000 shocks at about 1 to 4 pulses per second, right? So that means if I'm doing 1,000 shocks at 1 pulse per second, that means it's going to take me about 1,000 seconds potentially to deliver it. Now I know it says 1 to 4. I honestly usually did 6 to 10 when I was in the clinic, but that's what the book says here. Again, look what the treatment time is. Is this starting to get old yet? Treatment time lasts 15 to 30 minutes. Average treatment time should be 20 minutes. Almost all your modalities are going to be about a 20-minute treatment. We can use ultrasound and X-ray to target the energy specifically. So if we've got something like a non-union fracture or something like that. But if we're just treating trigger points or just treating plantar fasciitis or lateral epicondylitis, we don't need imaging. 20 minutes is the golden rule pretty much. You're exactly right. We don't necessarily need anesthesia, right? Meaning we don't need to numb the area. We especially don't want to numb the area before we figure out where the pain is, right? Because let's say I put something like lidocaine on the person's foot, and then I'm going, does it hurt here? Does it hurt here? Does it hurt here? And they're like, nope, 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 nope. Well, of course they're not going to say anything because guess what? I just numbed the foot. Same idea. I don't want to put that area that I'm going to treat with Shockwave on ice because ice is going to numb the area. I need to be able to find the areas I need to treat. But while I'm doing trigger point or doing Shockwave with trigger point release or plantar fasciitis or lateral epicondylitis, I can add something like a lidocaine to my ultrasound gel, which would work on that same idea of phonophoresis, where it's going to help push that lidocaine into the area and kind of numb the pain area. We do have to have a prescription for that. We don't want to do that right off the bat. Even though now you can go to, CVS or Walgreens or Rite Aid or any of those pharmacies and buy like Salonpas medication that has lidocaine in it, right? Just remember that in the medical field, we still need prescriptions to treat with medication, right? We can't just go do it. We can also deliver something like acetic acid for calcifications of tendons, as long as we have a prescription. So we're going to take and deliver about 200 to 400 shocks to one area. If the pain is not reproduced, so if we hit that with shockwave and the patient doesn't feel the pain, the area is probably not going to respond to shockwave, right? And it makes sense. If smacking it multiple times doesn't cause the pain to go up, this is probably not going to help because we're not going to get any relief from it. They're applied to the point of maximal tenderness at the lowest energy settings, meaning the areas that are really tender, we're going to crank down the intensity. The areas that maybe aren't as tender, we can crank up the intensity. We need direct patient feedback, meaning they need to tell us, they need to talk to us while they're going. And we will increase the intensity or the energy level within the patient's level of tolerance. This is not to make somebody cry, although some patients will cry from this. So I pulled 2 quotes out of 2 of the books that we have on the shelf. So, and this is just food for thought for all modalities. I really like this quote from your rehab book. Evidence for other biophysical modalities, such as ultrasound, laser, and shockwave, is generally weak, and prolonged use of these modalities is discouraged because they instill a passive approach to pain management. I like that quote. What does that say? It says we don't always constantly want to use modalities because what's going to happen?
Body's going to get used to
Patient
it.
will just rely on it.
Yeah, the patients become addicted to modalities. They legitimately do. Like I remember having patients coming in going, I don't have time for treatment today, but can you put me on the hot pack? What? No, right? And like this statement here from the Introduction to Physical Therapy, additional biophysical agents may be used in the treatment of patients with musculoskeletal dysfunction, including mechanical traction, hyperbaric oxygen, biofeedback, laser, shockwave, right? But the modalities achieve therapeutic benefit through mechanisms different from those of thermal electrical agents, but may also be used to decrease the patient's pain. So as you're noticing it, all of this is going to help decrease the pain, but modalities are not themselves going to treat the problem. Right? There was a clinic in town that's all they did was modalities. They would take cash pay, the patient would come in, get E-stim, get ultrasound, get laser, get whatever, and go. And yes, the patient will get relief from that, but it won't fix the problem because we haven't addressed the problem. All we've done is basically put a mask over it, right? Let's say that I'm going to use traction as an example. Let's say I have a disc that's kind of bulging and I get on traction to help that. While I'm on traction, great, that disc kind of shifts back to where it should be and my pain's relieved. But if I don't fix my posture, what's going to happen 2 days later?
Just go right back to how.
It's going to go right back. Yeah, right? So we need to see them for other treatments other than just modalities, and shockwave is included in this. Even with the great results I had for plantar fasciitis with shockwave, it didn't matter if I didn't fix what was causing the problem. If I didn't get, that the patient I had out of her 7-inch heels, she's going to keep coming back to me with the same problem every couple months, right? And let's just face it, most of when you're in a client facing or customer facing job, because I know a couple of you have worked in places like this where you've worked at casinos or you've worked at some of the restaurants, the actual shoes that they give you to work in aren't exactly the most orthopedic shoes in the world, is what I'm going to say, right? And so that leads to workers' comp claims, right? It leads to injuries. They don't care. You're exactly right, Bianca. They don't. All they care about is the way you look to present to the client, right? Because out-of-state millionaires don't want to see people coming in, you know, handing them drinks in Skechers or something like that. Shoes for Crews got you covered. Yep, exactly. So that's why this is important to understand. I think that's my last slide on this. I'm going to go back to my face here. That's one of the things that was important. I want you guys to understand is all these modalities you're learning in this class are great, and they're the basis for physical therapy treatment. But if we actually don't treat with physical therapy, they're going to keep coming back to us, and they will eventually become addicted to the modalities. Which is why if we have a patient that's on a long-term treatment plan, like something for a low back injury or something for a significant sprain or a strain, we want to start weaning off the modalities, right? When we first warm them up, we may warm them up with a hot pack, but later in the treatments, they should be warming up by getting on the treadmill, by getting on the bike, by getting on the arm bike. The other thing that does is it teaches them to not rely on that hot pack or cold pack for constant relief. They've got to fix their problems themselves. Even when we talk about patients that go to the gym regularly, most of the injuries that occur are from bad form, right? Would you agree with that? Most of the injuries that occur in the gym are bad form. Doesn't necessarily mean that's all the injuries, but a lot of them are bad form. And it may not be intentional bad form. Maybe the person never learned how to do a deadlift. I've seen people doing deadlifts where they, you know, never engage their core whatsoever. And they're wondering, why does my back hurt so bad? Well, duh, right? Or they're lifting more than their core can, and then they end up with a core tear. You know, form is important. So treating the patient both with modalities and with physical treatment is important. And the interesting thing, they did a study, a few years ago that showed patients that reported a higher satisfaction from their physical therapy were touched by their physical therapist or physical therapist assistant. And it can be as little as doing one stretch with the patient. You know, when they come in for therapy and maybe their whole exercise program is completely them doing exercises, we should have one thing in where we touch that patient, right? Because think about it, we are touch-based species, right? That human interaction, we kind of, some of us, I'm quite happy without it, but they do report better satisfaction from that. So we want to make sure that we adapt these modalities and the treatments to what they need. That's it for this lecture. Are there any questions?
No, I don't have any questions.
All right. So real quick before I let you guys go, because I don't think there's anything else she has me covering today. Remember that you have that quiz that's due, I think she said by Tuesday, right? Or something like that. There is the open lab tomorrow that's signed up for it. With regards to a class to help you guys prep for modalities final, would you like to do the same thing and do a recorded session next Thursday after your biology practical? Would that work out? You know, here's the deal. If, let's just say everyone passes their biology midterm, we could legitimately do that review on that Wednesday. That way you don't have to take time out of your day as well, right? If everyone passes and there's nobody, we can just do the review that day. But we need to make sure we still have that open just in case, right? So we'll plan for Thursday, and if everyone passes Wednesday, we'll just do it during Wednesday's biology for an hour or so and then let you go. I want to make sure you guys are ready for the modalities, because sometimes I find that the modalities final sneaks up on you guys and you thought you prepared for it, but it's a little harder than you expected because you've got numbers for E-stim, you've got numbers for ultrasound. It just sneaks up on you. Is that fair? All right. If there's no other questions, I've got nothing else to cover. That was the lecture for the day. So I appreciate you all coming in. I'm going to stop the recording.